everyone, and welcome back to another episode of MedSynapse podcast series, where we connect you with thought leaders shaping modern medicine. And today we are diving into a topic that touches millions worldwide, and it's very common usually an overview of allergy. From sneezing fits to life-threatening reactions, allergies are often misunderstood and underdiagnosed. And to help us decode it all, we have with us a brilliant expert in this field. And I'm thrilled to introduce Dr. Hitesh Billa, a clinical and therapeutic allergologist, interventional pulmonologist, and respiratory intensivist. Dr. Hitesh's accolades are exceptional. Best outgoing student during his MBBS, multiple gold medals and certifications ranging from allergy and asthma to critical care and interventional pulmonology. His dedication to advancing respiratory health and allergy care is truly inspiring. So, welcome, Dr. Hitesh, and it is such an honor to have such a great discussion with you today.
Thanks, Hetri. That was a wonderful introduction. Yeah, we can proceed for the session.
Yeah, Doctor. So, let's just start with our discussion today and actually a bigger picture. Could you give us an overview of the most common allergic conditions you encounter daily in your practice? And are you noticing any trends in prevalence, whether, globally or just regionally as well?
So allergy is a spectrum. It's just not a simple thing. So if you see, allergy is a multifactorial condition where there is a genetic predisposition history and the host tendency to get allergy and the environmental triggers. So it's a three-dimensional if you see. It's just not a simple disease. Like the three should be there to call it an allergy or to precipitate an allergy. So allergy is a spectrum. So if I can give an example, so one thing is, there is some stimulus and there is a response. So normally, for a normal person, the stimulus is normal here and he won't give a response. But in a patient with allergy, or say for example, the genetic tendency he has, so what happens? His body will assume the stimulus or a normal thing as an allergen and he gives a response in the form of allergy. It can be eye allergy, where the aeroallergen, the allergens in the air will be exposed. I mean, the eye is something which will be directly exposed to the air and the eye will have the symptoms. Similarly, if the air has allergen and the patient is inhaling, the nose will have the symptoms in the form of sneezes or itching or nose block or nasal discharge. So similarly, the same air with allergens will enter the lungs, giving a wheeze or chest tightness or a dry cough or sometimes shortness of breath. And the same, sometimes the skin getting contacted with the allergen, giving us symptoms in the form of allergic dermatitis or eczema. So this is a spectrum. It can involve any part, but these are the 5 things: eyes, nose, lungs, skin, and some people will get symptoms with the food exposure, which when the food is having allergens and in the form of stomach pain or cramps or dizziness or edema in the neck or difficulty in breathing, wheeze, or even fall in BPs, or maybe sometimes allergy can be life-threatening. As Hedvi was saying at the beginning, the name of the severe reaction, we usually call it anaphylaxis. And some people have tendencies to react to drugs or medications in the form of drug allergies. Yeah. And as Hedvi asked regarding the prevalence and incidence, so definitely if you look back the 2 decades, so I can say this, like allergy is being diagnosed in the right way now, so the cases are increasing. This is one aspect. The other aspect is, if you see, nowadays allergy is definitely a lifestyle disease. I can tell you in this way, the urbanization is increasing and parents with this current mindset, we should live in a very clean environment. So there is something called as hygiene hypothesis. So living in a clean place will deviate his immunity, the kid's immunity, to a Th2 type, which will predispose to an allergy or an asthma. So hygiene hypothesis is one thing. And if you look at some studies even say the increase in the number of cesarean sections is also leading to allergy, because the normal vaginal route of the delivery, where the kid will pass through the vaginal delivery, and in the form of the local microbiomes near the vaginal area, the kid will be exposed, and this will give a protection to an allergic response. And The same as I was telling you, hygiene hypothesis, like proper clean, this separate mindset the patients have to raise the kids in a very clean environment and increase in cesarean deliveries. And there are so many things I can tell you. Yeah. And there is one more theory. The more infections in the childhood will give him a non-allergy kind of a immunity. So this is one
Mhm.
aspect. And there are so many theories. Like if a pregnant mother is living in a house which is close to a main road, which has a lot of pollution, the high chances that the baby uh, the mother is going to deliver will have the possibility of asthma. But as such, if you look, Indians have, smaller lungs with a smaller lung function when you compare with the others. So this makes the treatment part a bit complex also.
It really shows how dynamic allergy patterns can
Yes,
be.
yes, yes.
Mhm.
Previous picture where the rural environment was predominant, there were no smoke, no much of industries. The people used to play in the soil, mud, and
Yeah.
that environment, the infections and infectious environment, I can say. So the allergy incidence was low and prevalence was low that time. So we can correlate now to the urbanization and the kind of lifestyle we are going towards. Yeah.
Correct. So, moving on to the next question, allergic conditions can, mimic or overlap with other disorders also. So, what are some common diagnostic pitfalls that clinicians should watch out for when evaluating suspected allergy cases?
The main challenge will be the patient who has allergy reaching the allergist, proper allergist.
Hmm.
So, so it's like the patient's mindset. So every patient will actually go to a general physician initially. So then they'll take the treatment in the form of over-the-counter medication sometimes. And the most commonly, I can tell you, allergy is being underdiagnosed or overdiagnosed, and undertreated or overtreated. So
Hmm.
nowadays, we can see there is evolving the field of allergy. The allergens are increasing, and the courses for the allergies also going on, and the doctors in this profession are rising. I think this will definitely lead to a better management of allergy and allergic diseases. So if you ask me pitfalls, right? So the main thing with allergologist when you compare with a physician or any doctor is taking a history,
Yeah.
because allergy history, yeah, allergy is diagnosed most of the time with a clinical history assessment, 80-90% of the time. And only 10 to 20% of the times the doctors will have a dilemma which may need extra diagnostic tests to get the proper diagnosis of allergy or to assess the severity of allergy. So common diagnostic pitfalls include the patient believing a doctor. If doctor diagnoses a condition as an allergy, especially this accounts for asthma. Patient will not accept the diagnosis of asthma. So you need to make sure that the patient should understand the condition. The main thing will be sitting with the patient for at least 30 to 40 minutes. So take a detailed history, then make him understand what exactly the problem is. Just because I'm telling you, the allergy is always a 80% of the times, 85% of the time, allergy is a clinical diagnosis. The history assessment, the more you talk, the more you feel them comfortable, they'll also start accepting the diagnosis. And if you require a further test, definitely they'll go ahead and you'll have a separate diagnosis and you can assess the severity. Yeah, this is one thing. And the one more thing is the patient will be so if your clinical history assessment is in a dilemma, you'll require some tests. The most commonly or the best screening tool to assess allergy is the skin prick test or skin allergen test. So where you will put the allergens over the skin and you'll give a pricks and
Hmm.
watch for the reaction 15 to 20 minutes and you'll see the response. The patient you can make the patient understand better and he'll accept, yes, this is my allergen because my skin showed response to this particular allergen, and when I was being tested to so many allergens, this showed a bigger response, so likely I am allergic to this particular allergen. So this is one thing. And so mainly patient before reaching your OPD will be on most of the anti-allergic medications, which makes your skin prick assessment a bit difficult because you need to stop the anti-allergy medications at least like 7 to 10 days to get the good results. So this is one aspect. So at the first sitting, you can't do a skin prick test if you are in a dilemma with the clinical history. And one more thing is the prices of allergy tests. So we have, if you
Mm.
can ask me, there are 5 or 6 different types of tests. So one is skin test, the other one is IgE. So IgE tells he has this allergic response in the body or not, but not cannot specify this allergen is giving the symptom. And then you have
Mhm.
the specific IgE, like if you are suspecting clinically to a dust mite, then if you ask for a blood test specific IgE to dust mite, this will turn positive. So this is specific IgE. So from the history, you'll have allergens, list of allergens. Yeah, I have 5 allergens. I have narrowed down this patient's allergy history to a 5 allergen exposures. So I want to confirm it through a blood test. The prices of blood tests are pretty high. Looking at the
Correct.
corporate laboratories, definitely I can tell you, you can't get a blood test at a lower price. But if government can provide this, that can actually help
Mm.
uh, at a lower price if the labs are providing tests that would actually help. And one more thing is the blood test will also have a false positive result. So the history is saying 5. The blood test may show 20. So then again, it should correspond to a clinical history. Then you should select. Patient will come to you. I have this is my report, and I have like 20 positive allergens. I'm eating it every day. I'm exposed to every day. I don't have symptoms. So that becomes it is something called false positives. Blood test will show positives, but the patient is not having any allergic history when exposed to that particular allergen. So detailed clinical history is always an important. That comes with sitting with the patient, talking to them, making feel them comfortable, getting information about the ambience of the patient, where the patient is getting allergy, or the food he's consuming,
Mm.
giving him a food allergy, or any exposure that is triggering his allergy symptoms and everything.
Correct. I think
Yeah.
that actually is such a key point, and it actually highlights the need for sharp clinical judgment also, Doctor.
Yes.
So now, what is your view on the role of multidisciplinary collaboration, like, ENT, pulmonology, dermatology in managing complex allergy cases?
So allergy, as I was telling you in the beginning, when I was explaining about the overview, eyes,
Mm.
nose, lungs, skin, and
Correct.
GIT, that is gut for the food allergies. So
Mm.
these are the 5 systems usually the allergy affects. So allergy is nothing but the hyperimmune response that identifying a harmless particle as a harmful thing, and your body will try to protect you in the form of allergy response. And these responses are nothing but the symptoms. Let it be a eye itching or eye redness, eye watering,
Mm.
nose block, sneezes, itching. That is actually like a response to send the dust particle out of your nose. And wheeze, cough, chest tightness, shortness of breath, or immediately having a severe abdominal crampy pain, or a skin rash, generalized deal response, or difficulty in breathing after having a food, or lip swelling, or even eyelid swelling, and immediately having a uh, after having a medication, giving a severe allergic skin response, or having an anaphylaxis. So there are multi-systems. This is what I want to tell you. Allergy coming to you with only one particular system is usually rare. So if a patient is coming to me as for asthma, as I'm a pulmonologist also, he'll also have a nose issue, definitely for sure, because nose reflects the lungs. If your nose is good, definitely your lungs will be taken care of. So your nose is having symptoms, and definitely this indicates or reflects your lung condition also. So every nose patient should be taken care of or look for the symptoms of the lungs, as I was telling you, all the symptoms. Similarly, you should also look for the eye symptoms. So we should also ask for eye itching. So if there are eye symptoms and they are significant, send the patient to ophthalmologist. If you have no symptoms, so usually allergic rhinitis is misdiagnosed with chronic rhinosinusitis. So for which the treatment is quite different. So you need an opinion from the ENT also. Sometimes these asthmatic patients will have nasal polyps. The
Mm.
polyps are like soft tissue structures that grow in the nose, which mimics, in the form of if the patient is having nose blocks persistently, not improving on nasal medications, he definitely needs a ENT opinion. And for food allergies, it's better to think and differentiate
Yes.
whether it's a real food allergy or a food intolerance. And if you have a doubt, get a medical gastroenterologist opinion to be taken.
Yeah, I think that actually that approach relies and really can change outcomes and it can signify also. So,
Correct.
doctor, do you notice significant differences in how allergic conditions present or progress between children and adults, and how does this impact your management strategies?
Yeah. So again, there are two things. Symptoms starting in the childhood, symptoms
Hmm.
starting in the adulthood. So if the child he has a genetic predisposition history, so
Hmm.
usually in the early part of the life, like the first 6 months of the life, he'll have dry skin rash, and itching, crusting of the skin, which makes the kid irritable, and followed by food allergies, especially if you look at the food allergies, cow's milk, wheat, soy, peanuts, tree nuts, there'll be multiple food allergies. And then as the boy grows or the girl grows, he'll have no symptoms. And then which will progress to the lung symptoms or asthma over a period of time. And patient will live with asthma, and the no symptoms, food allergies and skin will usually settle. So this is called atopic march. So patient starts with the skin allergy, eczema, then food allergies, then the nasal allergies in the form of allergic rhinitis, then you have asthma. So this is called atopic march. So when the child is having predisposition, genetically mother and father has the allergies, and child will have this something called atopic march usually. So this is kind of pattern which is classical, but sometimes anyone can present at any phase. The child may have, skin symptoms when he is going to school or a college or even doing a job. So this is what I'm trying to tell you. The asthma can present early, and skin symptoms may present when the child is in the when he reaches the age of 40 or 50. So as a to make it simple, early the presentation of allergy, early the diagnosis, early the treatment, better the options of management, better the options to control this allergy, so better the options to reduce the severity of the condition, and better we can stop the progression of allergy. So any allergy, if it is not properly controlled,
Hmm.
definitely this will progress. That is for sure. If it's not taking care of the medications, his health, and is just ignoring his health or allergies, and not avoiding the allergens he's exposed to every day, the allergy will progress. Okay,
Hmm.
and usually elder patients will have lesser response with the medications usually because of the chronicity of the allergy. So definitely, I can tell you, late the disease,
Hmm.
lesser the options, lesser the control, and more complex it usually becomes to manage, because end of the day, if you see the mainstay, I can't tell mainstay, but
Hmm.
allergy will be under good control with steroids. But steroids will have a lot of side effects. So you should try to avoid steroids with the proper medications and allergen avoidance measures. As I was telling you, this is a three-dimensional thing, from the host, from the environment. Genetic, you can't control. From the host should take a proper measures. From the environment, you should avoid the environment that has the allergen. So child, the diseases will be in the early phase, and adults, if the child not treated in the early childhood and he's not on the regular medications and he's not avoiding allergens and he's growing, the progression will be happening, and we'll have a lesser options, not lesser options. It makes more complex. Options will be there, but it makes more complex to sit, to discuss, to convince him for the other treatments.
Correct. I
And
think that's
yeah,
really insightful, doctor. So, doctor, could you share one or two cases that actually highlights the importance of early diagnosis or an interdisciplinary approach in allergy management?
yeah. So I'll share two cases
Mm.
from a little experience. So
Mm.
one case, she's a elder female, 60 years old, and she has history of allergy of almost like 15 to 20 years. And she
Mm.
lives in a rural environment basically, and she's a
Mm.
housewife. So now she presented with the symptoms that even on inhalers, even on oral medications, the
Mm.
symptoms were not coming down. So usually when the patient comes to us, We will evaluate history. We will ask history. We'll find out what allergen is causing. So that gives like that. With that, 50% of the work is done. Because what is giving you symptoms? If you find out that 50% job is done. Next thing is to diagnose the severity, how much severe with this allergen exposure or the other symptoms is involved. So this female, being a 60-year-old, 15 to 20 years, not on regular medications or not, she is taking on and off medications. SOS, if he has severe symptoms, she takes an inhaler for the asthma, and otherwise, no. As she is not able to, as she's a housewife, she usually stays in house, and she usually her physical activities are lesser. So usually for an asthmatic or anyone, unless if they work or do some activities that has physical stress or strenuous activities, they can't, we can't see their lung function. So if the lungs are involved, and definitely on exertion, they'll have the breathing difficulty. So for this female, I wanted to make it simple now. So she's not on regular medication, elder patient, and she don't know what allergen is causing the symptoms, and she is already on good amount of anti-allergy medications. So from the history, she lives in home and there are no triggers. So usually dust mite is one thing which can give the symptoms. So but we can't confirm because of her. She lives in a rural area. She can't tell particularly about it, specifically about it. And she was on and off medications, not on regular medication. But now she's on regular anti-allergy medication. So now the history-wise, we have a dilemma. And as she is on current antihistamines, we have a dilemma whether to do a skin test because most of the time it shows negative. And she has recently received something called as biologicals. The biologicals will make the Ig levels or the chemos or the cytokine levels lower, which makes it much difficult for us. So unless the patient is having a severe asthma or allergy, we won't usually prescribe a biological. So elder female, not on anti-allergy medications or asthma medications, or you can say on and off medications, currently with the severe symptoms that required biologicals, still we don't know the reason of the allergy, what is giving us symptoms. So the way we have to wait till the biological effect or the antihistaminic effect is gone, but we don't know because stopping of the biologicals or antihistamine will further worsen her condition. So she should be put on the medications for sure, and we should reassess every time at the follow-up. The whole thing of telling you case is early diagnosis of allergen. Identification of allergen is really important, which makes our job easier, rather than after going all the measures for the allergy, all the medications, all the last lines of medication, it becomes difficult for us to find out the allergen, because allergen avoidance gives 50, if you know the allergen, you can avoid it and your symptoms will be controlled along with the pharmacotherapy. So this is one thing where the diagnosis or finding out of an allergen has become late or delayed, and still we don't know, just because we are just waiting for her condition to improve and we can stop the anti-allergy medications or biological, so we can test for identification of allergen. So this is one thing. And the other case is a young boy who is 6 years old with the nasal symptoms, and he came and that fellow literally cooperated for the skin test. Usually a little painful, and kids will be afraid even if they're watching some music or any videos. Usually nowadays kids are watching Cocomelon and all. So still they avoid skin prick test. So but anyhow, we tried to explain the kid. He understood the task. So he's having allergy. He's not able to play with his fellow kids because of the symptoms, and which is the allergy is actually restricting his physical activities for so young age. So the young age is very important for the growth if he plays well, especially lung function. Good exercise will keep the lungs very good. Okay. So he cooperated for the skin test. We found out the dust mite and the cockroach allergens are responsible for the symptoms, and we started the patient on allergen. I told them what precautions should be taken to avoid the dust mite and the cockroaches regularly, and he's on inhaler And we also explained something called as immunotherapy. So immunotherapy is something, this allergic response will be desensitized. I mean, the patient will tolerate the allergen exposure. So with the regular exposure of small doses in a graded response exposure of the medicine, so his body will start taking the allergen, or you can say the body tolerance will build up for that particular allergen. So we are actually planning the immunotherapy for that patient because he can't continuously control the exposure to dust or cockroaches because they're predominantly indoor.
Yeah, I think these real world examples are really interesting to know, and thank you for sharing those, Doctor. And Dr. Hitesh, this has been an eye opener, and thank you for your time and sharing your expertise on allergy care. So, thank you so much for joining us today, Doctor.
Thank you, Hetri. Thanks for giving this opportunity. Hetri, all the best.
Thank you, Doctor. And to our listeners, stay tuned for more conversations that inspire, inform, and ignite change in healthcare. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, let's do something good for this world and leave with a smile. Thank you.